Assalamu alaikum and welcome to the second part of the conceptual basis of urology course. We will be making a formal opening of the conceptual based course from January next year, and this is a preliminary lecture. Today we'll be covering the upper tract urothelial cancer. It's an enigmatic cancer. It is something that we know very little about, and it's because of the relative rarity of this disease. Now, I have no disclosures and my acknowledgements to the current European Association guidelines and a few lectures on the Euro today. Well, the risk factors of urothelial cancer of the upper urinary tract, starting from the collecting system down to the urethra, is essentially very similar to the urothelial cancer of the bladder. Cigarette smoking being the #1 cause, followed by use of certain herbs, particularly used in Chinese medicine and as vegetables, called with high content of aristofolic acid. Alcohol consumption, again, is important and particularly related to the amount of alcohol consumed. So cigarette smoker, 2.5 to 7 times the risk if you are a smoker. For ever drinkers versus never drinkers, the odds ratio is 1.23, and the confidence interval is 1.08 to 1.4. So there's a significant chances that if you are a significant drinker with greater than 15 grams of alcohol per day, which is equivalent to all these things, there is significant chances of patients who've got bladder urothelial cancer, they are also at risk of developing. Just a quick review of the TNM classification, and because we will be referring to this classification throughout the talks. Well, TA is no different from what it is in the urothelial cancer of the bladder. Non-invasive papillary carcinoma is TA, TIS is carcinoma in situ. If it is invading the subepithelial connective tissue, it is T1. If it goes into the muscularis layer, T2. And for renal pelvic tumors, if it is going into the peripelvic fat or into the parenchyma, it is T3. For ureteral tumors, if it goes into periureteral fat, it is T3. T4 if it goes to the adjoining organs. Nodal and distant metastases as most of the tumor. Now, CT urography is the cornerstone of diagnosis. It has a high sensitivity and a specificity. MR urography in certain situation when CT cannot be done, but it is less sensitive than, and you need to have a tumor which is greater than 2 centimeters to be able to be picked up on MRI scan. Cytology is very important, and Babotage cytology during ureteroscopy provides excellent diagnostic tool for differentiating between urothelial low-grade versus high-grade cancers. And as we know that high-grade cancer and CIS have a greater chances of a positive cytology, the sampling of tissue from histopathology is often not very representative, and it's possible that you miss out high-grade cancer. But cytology positive, even if you have a low-grade cancer, you're dealing with a high-grade cancer. Ureteroscopy is the endoscopy of choice for diagnosis of both ureteral and renal, pelvic, and collecting system tumors, with some modification in the recent years with the use of narrowband imaging. And then there is virtual pathology using optical coherence tomography, which, as you can see, that you can make a virtual decision about whether you're dealing with a dysplasia versus low-grade tumors, high-grade tumors or muscle invasive disease. And this can be determined per endoscopy rather than wait for histopathology. A recent innovation with the use of confocal laser endomicroscopy is another new way of identifying. This is normal epithelium, this is high-grade cancer, and this is low-grade cancer. So you can actually, while looking at the tumor, and if you look at these two pictures, it is very difficult to make out whether we're dealing with a low grade or high grade on a regular cystoscopy, ureteroscopy, whereas confocal laser endomicroscopy can actually differentiate preoperatively. So these are still in the as investigative tool, and their widespread availability is still an issue. As far as I know, they're not available in Pakistan at the moment. Well, when you're doing an initial assessment, systematic screening during medical interview is important. Suspicion of upper tract urothelial cancer from history is typically on patients who are 65 years of age, under 65 years of age, with history of Lynch spectrum cancer. And this is polyposis coli, with which can give rise to upper tract TCC as well. So these are the patients who have what's called a Lynch syndrome. And if the first degree relative under 50 years of age has a Lynch syndrome, there is a higher possibility of developing a hereditary upper tract urothelial cancer. It can be sporadic, and in this situation, when you have a suspicion of a Lynch syndrome, then germline DNA sequencing is what is recommended. The management depends upon low versus high risk cancers, and if we remember, majority of the patients being treated by nephroureterectomy, which at times is an overkill. So if you have a low risk cancer and a low risk cancer, it's important that all these features must be present. It should be a unifocal disease, it should be less than 2 centimeters. The cytology is negative for high-grade cancer. It's low-grade on ureteroscopic biopsies, and there is no invasion on CT. Whereas high-risk cancers, if any of these features, i.e. the multifocal disease or tumor size greater than 2 centimeters, cytology positive, high-grade on ureteroscopy and histopathology, CT evidence, presence of hydronephrosis, previous radical cystectomy for high-grade bladder cancer, and presence of variant histology, they're all high-risk cancer. And if any of these factors is present, then your patient has a high-risk upper tract urothelial cancer, and the management is quite different. Now, I start off with one of the cases that we have very recently managed. 73-year-old male, diabetic, hypertensive, ischemic heart disease, status post PCI, and he denies any addiction. He was referred by the nephrology colleagues because there was hydronephrosis and hydroureter with worsening renal function. His CT scan with contrast could not be done because of the creatinine. And so he was planned for a ureteroscopy and a retrograde pyelography. And you see in this retrograde pyelography with the ureteroscope in place, that the middle and the proximal ureter is significantly dilated and tortuous. When we did a cystoscopy, we found that there was soft tissues coming out from the ureteric orifice, and the ureteric orifice itself, once we enter the ureter, we found that there is a definite tumor. The microscopy showed high-grade urothelial cancer with carcinoma in situ. No convincing evidence of lamina propria invasion. So irrespective whether it's TA high grade or T1 high grade, it's a high risk cancer because the volume was greater than 2 centimeters and the histopathology was high grade, cytology was positive. So all this together, this is a high risk cancer. The patient had a PET CT because we couldn't do a contrast study. As you can see in the PET CT that there is a large cyst in the lower pole of the left kidney. Double J stent can be seen in the, which was placed after the ureteroscopy, thickening of the ureter, dilatation, and some periureteral stranding was identified on the, there was no distant metastases or lymph node disease. So he underwent a nephroureterectomy, and essentially it just showed that it was a T3 disease with the involvement of the periureteral fat. So post treatment PET scan, which was done 8 weeks after the surgery, so far has shown no evidence of nodal or distant metastases. The question really is about the use of adjuvant chemotherapy for these high-risk cancer, PT3 disease, and the evidence coming from the POUT trial again is important. And if you remember, very recently in the Journal of Clinical Oncology, in the meeting abstract was published with the updated data on the POUT trial with 261 patients who were randomized into either receiving 4 cycles of gemcitabine, cisplatin, or carboplatin, depending upon the creatinine. If the creatinine was less than 50, patient received carboplatin rather than cisplatin. And the other group underwent surveillance. The chemotherapy group had a 28% reduction in the relative risk of death in the extended follow-up, which was reported this year. The 3-year overall survival was 67 versus 79% between the observed, the surveillance group versus chemo group. And there was no evidence of long-term toxicity associated with the chemotherapy. So there's evidence in POUT trial that adjuvant chemotherapy can improve overall survival in high-risk patients. Well, nephroureterectomy itself is the cornerstone of the management, and it is either done open, laparoscopic, or robot-assisted. We know that there is various ways of doing it, particularly for the bladder cuff. There could be either 2 incision if you're doing open, single incision flank approach in which the bladder cuff is excised endoscopically preoperatively. So all these various ways of doing it, there is very little data indicating one is superior to the other. And even comparing lap versus open versus robot-assisted, again, the data is very consistent that there is no oncological advantage in doing a lap or robot-assisted compared to open. And in fact, EAU guidelines recommend that if there is nodal disease, it is preferable that open or robot-assisted procedure should be performed. The lymphadenectomy is an important part of the procedure. If there is high-risk disease with evidence of nodal disease in the preoperative imaging workup, then it is important that the template-based nodal dissection should be performed. And as is indicated in the diagram, depending upon the site of the tumor, the template dissection of the nodal disease is, or nodes are removed. And there is evidence that the high stage PT2 tumors, the nodal disease range from 14 to 40%. So if you look at the summary of the guidelines, the radical nephroureterectomy is the standard treatment for high-risk upper tract urothelial cancer, regardless of the tumor location, whether it's in the ureter or it is in the renal pelvis and collecting system. Open laparoscopic and robotic approaches have very similar outcomes for organ-confined disease. Now, failure to remove the bladder cuff increases the risk of bladder recurrence. So it's important that the bladder cuff is appropriately removed. Lymph node dissection for muscle invasive, meaning T2 plus disease, is important, and template-based dissection should be performed. Postoperative chemotherapy improves disease-free survival. And a single postoperative intravesical chemotherapy decreases the chances after radical nephroureterectomy, decreases chances of bladder recurrence. So this is the summary of thing, and it seems like we are done. And whenever a patient comes with upper tract urothelial cancer, do a nephroureterectomy. But there is more to this disease than these guidelines. So let's look at what would you do, and this is a question for all of you, that if you have a distal ureteral tumor in a patient with urinary diversion, be it orthotopic new bladder or an ileal conduit or a percutaneous pouch, would you do a retrograde approach for the diagnosis and biopsy of the suspected lesion? Would you go antegrade? You go open or laparoscopic approach, or perform a rendezvous procedure? So mark your answer as A, B, C, D, and we'll discuss the responses. Now, as we see that the upper tract urothelial cancers are diagnosed using ureteroscopy, and with the flexible and finer ureteroscope available, now you can actually access every part of the upper urinary tract from the ureteric orifice up to the infundibulum and calyx. But sometimes you need to use percutaneous approach as well. And the goal of percutaneous approach is very similar to the retrograde endoscopic or endourological approach, so that you have to obtain tissue and washings for cytology, ablate and resect the tumors. The pros of larger instruments, the pros of a percutaneous approach is larger instruments, which helps in better grading and staging, so you can take care of big bulk of tumor. You can leave a nephrostomy and come back and remove rest of the tumor if you've not been able to do it first go. And you can also administer adjuvant treatment using a nephrostomy catheter. The downside of percutaneous approach is bleeding, infection, and tumor seeding. Now, as for the tumor seeding, there are anecdotal evidence that percutaneous approach can actually result in seeding of the tract. When should percutaneous approach be used? Well, in cases of anatomically challenging cancers, which includes large bulk of tumor in the lower pole calyx. We know that percutaneous approach can resect greater bulk of disease. However, there is increased invasiveness and perioperative morbidity. Adjuvant therapy after the endoscopic biopsy and resection, you can use chemotherapy or BCG. More frequently, chemotherapy is used, but all depends upon the kind of pathology that you encountered. So it has to be tailored. The CIS, definitely, if there's a primary CIS, BCG is the drug of choice. You can either administer retrograde chemotherapy. intracavitary chemotherapy by retrograde catheter and slow irrigation of the tract. You can use a double J stent with the intravesical installation, and you can use an antegrade approach by putting in a nephrostomy tube and running chemotherapeutic agent for intracavitary installation. We know that the upper tract tumors have a high incidence of recurrence, so surveillance using sectional imaging and ureteroscopy are imperative. Well, another question for the audience. The question is there a realistic risk of tumor seeding in an antegrade approach to upper tract urothelial cancer? And your options are, and you can mark in the chat box as A, B, C, and D. It should not be used due to reports of tumor seeding in the tract. B is there is no good quality evidence for tumor seeding. I'm not sure, and there is only anecdotal evidence in support of tumor seeding with the percutaneous approach. So you can write your question, you write your responses now, and we will discuss them in a little while. So retrograde approach is basically has the advantage that the low volume disease, both in the ureter and the renal pelvis, can be managed with a very low morbidity as a day case procedure in most situations. The antegrade approach, as we have said, is for large volume renal disease or proximal ureter, when retrograde approach is not possible, like in a situation that we have discussed, that it's almost impossible to cannulate the ureteric orifice in a case of urinary diversion, like in the form of an ileal conduit or an orthotopic new bladder. So you have to have some either a rendezvous procedure or you come from above. Lower polar again is something very difficult to manage in a retrograde fashion. So it's best that a significant bulk of lower polar disease should be managed by a retrograde approach. So small isolated of few tumors, single stage biopsy and resection and fulguration. So if you have small tumors, you can do everything together. So you take a biopsy, you fulgurate the base using laser or electrocautery using a Bugby, and that would take care. Although you need to be careful about the fact that the chances of stricturing is significant, so you need to be careful when you're using either laser or electrocautery. For larger volume tumors, it is sometimes better to stage them with biopsies taken. Second stage, you can go in and do fulguration. If your initial histopathology comes out to be low grade with a cytology negative. If you have a T1 or T2 and high grade nephroureterectomy with either new adjuvant or adjuvant chemotherapy is what is recommended. If you doing some form of nephron sparing or kidney sparing procedure, antegrade adjuvant intracavitary chemotherapy via antegrade approach, retrograde approach via ureteric catheter, or retrograde approach via JJ stent. The last one is the least favorable because it hardly ever works. So presuming that the double J stent will result in significant reflux and irrigate with chemotherapy with intravesical installation is something that has not been clearly proven in literature. Postoperative bladder installation is important, and it should be done as soon as possible after the radical nephroureterectomy. You can use mitomycin C within 2 to 10 days of a nephroureterectomy. Sometimes really depend upon your bladder cup excision technique and a cystogram be done prior to installation of intravesical chemotherapy after radical nephroureterectomy, because you don't want to really put the chemotherapy in the extravesical or perivesical space. Now, this is a case that is not mine, and I'm going to discuss it for the sake of clarifying a few issues related with a high risk upper urothelial cancer. So, 64-year-old male who presented with gross hematuria, initial workup with cystoscopy was normal. Past history is only controlled hypertension with family history of cardiovascular disease. He was a never smoker. His creatinine was marginally high with a GFR of 59. Hemoglobin is fine, and the cytology showed atypical urothelial cells on Paris 3 grading. So this is Paris staging, Paris system of reporting urine cytology, and Paris 3 is atypical urothelial cells. Now this is neither here nor there. So if you see that the clear cytology is like non-diagnostic or unsatisfactory, 1, negative for high-grade urothelial cancer. Number 4 is suspicion of disease, whereas presence of atypical cells is an unclear area, and it could be in either direction. So these are the guidelines of what you should, how in an algorithmic fashion, as prescribed by the Paris grading system and the consortium that has reported this system some years back. So coming back to the case, this gentleman, as you can see, has obstructed kidney hydronephrosis. As you can see that there is significant tumor burden in the renal pelvis, and there is loss of parenchyma. There was no parenchymal invasion reported on this CT scan, and these are the 2 films that we are looking at. If you look at another axial section of the same gentleman, there is an additional finding in this CT compared to the one that I have shown you previously. So let me go back to this one, have a close look at the CT scan, and now we go back to this second axial set of axial sections, and there is an additional finding. So let's put it into an MCQ. What is the diagnosis? Is there a bilateral upper tract cancer, unilateral obstructive neuropathy, right renal pelvic tumor, or right tumor collecting system involvement with the tumor? So write your answers now. And let me show you the additional finding on the CT scan. So if you look at this is an IVC here, this is aorta, and between the IVC and aorta, there is another rounded structure. Now, this is a highly suspicious thing, which is likely to be an aortocaval node. And with the presence of disease in the kidney, there is a great suspicion that this is disease with nodal metastases. Obviously, the next step is to have a histopathological evaluation. So this gentleman underwent a ureteroscopy with multiple biopsies taken. They actually took 6 biopsies from primary papillary tumor filling the upper tract and funneling into the proximal ureter. The pathology came out to be bland papillary urothelial neoplasm, which is either PUN lump or PUNLMP or low-grade TA, and the pathologists were really between these two, but not high-grade disease. The cytology from the upper tract still showing atypical cells. Now, so you are in a certain situation now that your histopathology is showing a low-grade disease. Your urine cytology is not clearly indicating presence of high-grade or CIS. You have significant burden of cancer in the upper tract, and you also have something sitting between the aorta and the vena cava. So what would you do? How will you manage this patient? Will you do sampling of the lymph node nephroureterectomy with the template-based section of the lymph node? Would you do chemotherapy followed by nephroureterectomy plus nodal dissection? Would you do a percutaneous biopsy to get a better specimen to show if there is high-grade cancer, so that your decision about nephroureterectomy and do a nodal biopsy? Or would you do a PET scan? So this poll is open. Kindly vote now. And let me summarize. Gentlemen with low-grade upper tract urothelial cancer greater than 2 centimeters, large bulk of disease. However, his pathology is low-grade and there is no carcinoma in situ, and the urine cytology is also not clearly positive. So, and there is a suspicious note. Okay. So how was this case managed? Well, they were able to do the biopsy of this node. The reason why the biopsy was not considered initially was that the location is very tricky, sitting between the aorta and the IVC. So with difficulty and CT guidance, the biopsy was done, in which shows atypical with the highly suspicious of malignancy, and the nephroureterectomy decision was then made. So lymph node dissection was done. The hilar, paracaval, retrocaval, and intra-aortic caval lymph nodes were removed. The pathology was again TA and not, with 21 lymph nodes. However, the grading was high grade. So, and this patient is 2 years down the line with no evidence of disease. So you can understand the dilemmas involved in management of this cancer. Okay, so I mean, nephroureterectomy has been the mainstay for management, and as we have shown in 2 cases so far. However, one should remember that patients who have a radical nephroureterectomy have a poorer overall outcome if their other kidney is also not very well functioning, and which is a situation in majority of patients in this age because of various medical conditions. So if your estimated GFR is less than 45 versus greater than 45, you can see that the big divergence in the Kaplan-Meier curve indicating survival difference between these 2 groups. So it's important that we need to look at the other kidney. And it's important that if it is possible, we should try and preserve these kidneys and do some form of nephron sparing procedures. So nephroureterectomy, the kidney sparing procedures are, the indications are imperative and elective. Some of the imperative approach indications for nephron sparing procedures, solitary kidney, or bilateral tumors, and poor candidacy for dialysis and transplant. The elective indication, which should be exercised in sparing the kidney, includes low-grade, low-volume, non-invasive tumors. And as we said, the low-risk tumors are the one that should be. So ureteroscopy treatment should be preceded with a biopsy. Use a 3-cup biopsy forceps and biopsy forceps, 1.7 Charrier nitinol baskets with the steel wire baskets are all available. Ureteral access sheath, once you have examined the whole ureter, is again very helpful in decreasing the tumor seedlings into the lower tract and also providing access for repeated entry into the system. The holmium YAG or ND YAG laser, again, are very helpful in decreasing the chances of stricturing following, but you can also use electrocautery using a Bugby if it is not available. So these are the various types of biopsy gadgets, and they help in getting an appropriate specimen, which is much more trickier in the upper tract compared to the bladder. So the upper tract, for upper tract low-grade urothelial cancers, diagnostic ureteroscopy has been shown to shift the management from invasive nephroureterectomies for almost all of these patients to kidney-preserving surgeries. The lack of metastatic potential related to the pilovenous backflow during ureteroscopy is clearly demonstrated in studies. So one should not be concerned about the fact that when we do long flexible ureteroscopies in resecting and biopsying these tumors, the reflux or pilovenous backflow can actually result in metastases. And there is very little evidence in that. But however, the intrarenal pressure should be kept as low as possible. The biopsy techniques and sampling processing should be standardized so that, because these are the important tools on which decisions are made. So close coordination with the pathologist is extremely important. Urine cytology should always be performed. And sometimes the fluorescent and cytohybridization technique and use of various molecular markers can be helpful in deciding about the treatment options. So I have questions for you. For low-grade upper tract urothelial cancer following tumor resection, which modality would you consider for intracavitary chemotherapy? You would use intravesical chemotherapy with a double J stent so that it reflux and goes into the upper tract and provide topical impact on the urothelium. Use intravesical chemotherapy only. Use intracavitary chemotherapy via PCN, or use intracavitary chemotherapy with a ureteric catheter attached to the chemotherapy drip, with slow drip. So you can vote now, and from subsequent discussion, you'll be able to get the answer to this question, and also from what we have discussed so far in the presentation. So the second question is, during the course of management of low-grade upper tract urothelial cancer, when will you do ureteroscopy for contralateral side? Now this is an important area, because contralateral involvement is a possibility. We know that urothelial cancer is a field change disease. So if bladder is at risk, the contralateral urothelium is also at risk from the systemic carcinogenic influences. So you would do it, the contralateral normal side surveillance, whenever you are doing surveillance ureteroscopy for the affected side. Only when there is progression of the disease that you would go to the other side and see. Only on clinical or radiological evidence of disease, or once a year. So you can mark your answers as A, B, C, D, and we will again try and clarify these points. So this is another case, and again, this is not my case. So I brought it here for the sake of making a point. 71-year-old male with microhematuria found to have a 7 millimeter lesion in the distal ureter. The history of right hemicolectomy for colon cancer about 8-10 years back, which was T3N2A disease with no metastasis. The tumor immunohistochemistry shows loss of PMS2, MLH1, and is MSI high. So all these immunohistochemical markers are important because of the association that we have talked about early on. The patient is diabetic, he's mildly obese, good performance status, functional capacity is good, and he has a history of 25 pack years of tobacco with a good GFR. So this is a case by Serena Mateen. Now, the markers that we have talked about basically are markers of DNA repair. So when there is a DNA damage, there is DNA repair, and there are various pathways through which this DNA repair mechanism is impacted. And this is either due to mutation or due to germline, hereditary influences, and unrepaired DNA damage results in cells with damaged DNA, and this damaged DNA can actually become a cancerous cell. So this is a generic pathway, and the markers that I've talked to you about and in this patient are basically an indication of this pathway resulting in recurrent cancer. So this gentleman had a colonic cancer and subsequently this part of the Lynch syndrome. So I'm not going to go into the details of this immunochemical markers, and but these are important things that you need to keep in consideration. So these patients are at increased risk of with these mutations and with the immunohistochemical expression of these DNA repair gene defects would result in upper GI tumors, colorectal cancers, ovarian cancers, prostate cancer, urogenital cancers, endometrial cancers, and brain cancer. So this is more of a systemic condition which needs to be looked into, because patient can move from one disease to another, like the one that we are discussing. So coming back to the case, in November 2018, he had a cystoscopy, ureteroscopy, and retrograde pylography. 1.5 centimeter papillary tumor on a stalk was identified. The tumor was unifocal. The ureteric orifice was a bit tight. It was dilated. The tumor was completely removed, and base was laser ablated with a single dose of intracavitary gemcitabine was given in the postoperative anesthesia care unit, post-anesthesia care unit, with an indwell time of 90 minutes. So that's an important consideration, and one should look into this very carefully, that the chemotherapy contact time with the mucosa is one of the most important determinant of its impact. So subsequent follow-up in February 2019, TURBT was done for a 1 centimeter posterior bladder neck tumor with 0.5 centimeter papillary tumor in the lower calyx. All came out to be pathologically TA low grade. He underwent a total laser ablation with a single dose of intracavitary gemcitabine in the postoperative care unit. intravesical actually. Now, so he has disease initially in the ureter, and now he has disease in the upper tract, and he has disease in the bladder, although all is coming out to be TA low grade. So how would you, what would you recommend as a means of treatment in this patient at this time? Whether nephroureterectomy of the upper tract for the upper tract urothelial cancer, an intravesical MMC for the urinary bladder urothelial cancer be done. You resect plus pass the double J stent and do intracavitary double J stent related chemotherapy, or you do intravesical chemotherapy with intracavitary separately for this patient, or the other option is to resect and rescope. So various ways of putting intracavitary or intravesical chemo versus just resect and rescope, as you would do if there is a bladder cancer recurrence with a TA low-grade disease. So he was actually resected with 6 cycles of intracavitary chemotherapy given. And in June 2019, on the second surveillance ureteroscopy, showed an 8 centimeter tumor in the upper tract, which was involving significant area with the stricturing of his ureter, which required dilatation. The stent was placed. Still his kidney is functioning well. What would be your next step? Is nephroureterectomy an option now, or would you still consider treating this patient using bladder kidney sparing techniques with either intravesical or intracavitary chemo plus resection of these tumors? The patient was not willing for nephroureterectomy, and he underwent placement of a nephrostomy tube in the upper pole calyx with intracavitary installation started. So the method is that you give it 1000 milligrams of gemcitabine or mitomycin C in normal saline, and with slow drip irrigation at gravity for over an hour every week for 6 weeks, as you would do for bladder. So he was on maintenance chemotherapy when ureteroscopy was again done. Again, you can see a stricture. And at this time, his trigon was really very, showed a tumor. Ureteroscopy was negative. Again, the bladder is now showing multiple tumor. There is tumor in the bladder neck area and the prostatic urethra, and the CTU is showing multiple filling defects on the right side. Now, all this is indicating a significant recurrence of disease. Options is to either do change the chemotherapeutic regimen to another chemotherapeutic agent, to use BCG rather than intracavitary chemotherapy, or use the new drug which was available by that time called Jelmyto, and we'll talk about Jelmyto in a little while, or do an nephroureterectomy. The symptoms of low urinary tract are worsened, and but he still wants to retain his kidney. So BCG for bladder was started, and subsequently he was rescoped. And at that time, he has quite a few recurrences in the upper tract, and ultimately the decision was now made and the patient agreed for a nephrorectomy. This is nearly about 2.5, 3 years down the line from his initial diagnosis to the ultimate treatment of nephrorectomy. So he underwent a nephrorectomy with bladder cuff excision and intravesical installation of chemotherapy. Fortunately, his disease is still confined, and he had a P0 and M0 with clear resection margins, R0 disease, low grade, still low grade urothelial cancer. So these are notorious for recurrences, and at times when you keep seeing them again and again, it does not really mean that they have also progressed in grade. So there is still a possibility, if they can be managed endoscopically, to continue managing them endoscopically. The reason why intracavitary chemo does not work as well as the intravesical treatment, there are many reasons, and one of the reasons is that the contact time of intravesical treatment is relatively low for upper tract urothelial installation compared to bladder, which is a reservoir rather than a conduit. So this trial reported by Kleinman and al. In the Lancet Oncology last year. It's an open label single arm phase 3 trial with 74 patients enrolled and given at least one dose of Jelmyto, which is thermal polymer of mitomycin C, which becomes hard on low temp and on high temperatures, so it stays in the system for a little longer. This study, they have found out that the complete response rate was in 42 out of 15 of 74 patients, and this complete response lasted 11 months. The most commonly reported side effects included ureteric stenosis, urinary tract infection, hematuria, flank pain, and nausea. Some patients had significant drug-related side effects, and it has to be stopped. There was no reported death in the trial. So, coming to a conclusion, the upper tract urothelial cancer risk stratification is important and offer kidney sparing management as primary treatment option for patients with low risk tumors, and there is strong evidence and support. Offer kidney sparing management like distal uretrectomy for patients with high risk cancers, which is only confined to the distal ureters. The evidence is not very strong, but it's something that can be done. And if there is an imperative indication for kidney sparing, that should be done with a clear understanding that the patient would require very strict follow-up, and these decisions should be made on a case-to-case basis. So, how many of you know this gentleman? If you do, please write the name in your chat box. Okay, so famous surgeon, Alfred Blalock. Alfred Blalock is famous for tetralogy of Fallot. 4 defects, children called the blue babies, and they would die within few years of birth if not corrected, and this is what used to happen. Alfred Blalock, along with the pediatric neurologist Tussing and a lab technician, a black gentleman, Vivian Thomas created a new operation to relieve these babies of this congenital defect, and made history. And that was the beginning of cardiac surgery, to be honest. It was only in the middle part of the last century. But why I'm talking about Alfred Blalock is that Alfred Blalock was the graduate of Johns Hopkins. However, he was considered as an average student and was not given residency in surgery in Johns Hopkins, and he went to Vanderbilt in Tennessee, where he did his residency training and started his initial work there, and subsequently moved to Johns Hopkins. Why are we talking about him? It's because that Blalock, when he was young and was living in New York, he was a big-time smoker, and he developed tuberculosis, and his kidney was removed. And in the ureteral stump, he developed an urothelial cancer, and which remained unrecognized and undiagnosed until he one day collapsed during a state-of-art lecture of American College of Surgeons meeting, and subsequent workup showed that he has metastatic urothelial cancer, and he died of that cancer. So this is an interesting movie, an HBO movie on this. So all of you who are interested should go and watch this movie. So in the end, I must say that this disease is really enigmatic entity, and it is like Alan Turing's famous novel called The Enigma, which was source for a play called Breaking the Code, and a movie by in which the Cumberbatch also acted, called The Imitation Game. So I hope I've been able to clarify some of the queries and concerns and gaps in your knowledge about upper tract cancer, and I'll be happy to take any questions.